Yes, that's a good question. As I said earlier, we don't have these PET scan machines in Kenya, in East Africa and the region, and even Central Africa. So we are expecting a lot of patients from those countries. And already we have about 10 of them, Isaac, that have already booked. So we expect to see a lot of those patients. As you have seen, members of the press, we have a hospitality center just on this side here. It's a 100-bed hotel, and we were anticipating that Kenyans who are going to come from far and also from the region, if they come a day earlier and maybe they want to stay a day later, they can also use these facilities here. So we took care of that also. Thank you.
So basically, you start with your name and your position, what it is that you do, and then now we can keep taking the questions.
Okay. Good afternoon, everyone. This is Dr. Harish Nagaraj. I'm the nuclear medicine physician at Kenyatta University teaching referral hospital.
Could you please explain to us?
Cups to make sure that they're stable, and once we get a referral from the oncologist, we inject the patient with something called as FDG, fluoroxydeoxygen glucose, and this is the one which gets concentrated. It's a glucose analog basically. It gets concentrated in the cancerous cells in the body. So depending on the area of affection is what the doctors now decide where the treatment should be given.
And at that particular point, does the patient now become radioactive?
Yeah, actually the FDG's half-life is around 110 minutes. So approximately 2 hours the patient is quite radioactive. And however, like once, since the half-life is around 110 minutes, like after 2 hours it's gonna get reduced to half of its activity, earlier activity. The same applies for the weightage of next hour. So technically, after like 3 hours, the patient is has a very negligible radioactivity. Yeah.
And after the process, when they go into the scanning room, now what is the process that you as a doctor?
So let me tell briefly about the procedure from the injection time. So once the patient is injected, we give them around 55 minutes to 1 hour for the uptake time, what we call as an uptake time. And this is just mainly to make sure that the glucose is disseminated in the body and concentrates in the area of need. For example, be it the cancers or any other inflammations. And once the patient is waited for about 1 hour, they're good to go to the scan room. And we have a set protocol with our latest digital machine. It will not take much time for the scan. Usually the scan time is around 25 minutes. So by 25 minutes, the patient is out and we have what we want. The images are already acquired.
Okay. How accurate are these images, perhaps compared to the former forms of testing?
So earlier what we had was more of conventional imaging, whereby we used to get 3D images of the body structures anatomically. And what PET does is it is giving a combination of both functional image as well as the CT part of it gives the anatomical correlation. So earlier we used to know whether there is some kind of lesion there in the body, but we didn't know whether it is still metabolically active, it's growing, or it is having some other impact. So with the advantage of both PET as well as CT, we will get to know the metabolic activity of the particular tumor and also the exact location. So this is something which was not found in earlier conventional imaging. So this will be a big boost for the management of cancer and diagnosis.
So after the scanning, does the patient go home, or what happens? Because
So
are they still radioactive?
no, that is what I was trying to explain earlier. So once the radioactivity is negligible, we let the patient go just like any other scans. So there is no